medical oncology here. So I'm just going to introduce Dr. Cruz again. She's a medical breast oncologist who works here at the Cleveland Clinic. She's a clinical investigator. And as you guys have heard, her main area of research is optimization of care for patients with invasive lobular cancer. She's also Associate Program Director for the Hematology Oncology Fellowship.
Thanks, everyone, and thanks for staying. I know that after lunch it tends to get tough. Your bellies are full, and it's hard to take in a lot of data, so I'll try to make this as realistic and real-world as possible. And, you know, I think the medical oncology talks here are tough because there's a lot that we're worried about and a lot that we think about, but how much data we actually have for lobular, it's still pretty sparse. So I tried to put together everything that I could find, or at least the things that touch my day-to-day decisions. And so this slide here, why should we consider histology in our treatment decision-making? I mean, I think each one of us in this room can probably create a list of 10 reasons why knowing that a patient has lobular cancer is important. But I think if you have to pin it down and say, from a data perspective, why is it? It's really in the lower right-hand portion of this screen where you look at overall survival stratified by histology. And so in these curves, we see the ILC patients represented in red and the IDC patients represented in blue. And so even though we talk about ILC being less aggressive and we don't necessarily have to give chemo and the prognosis should be good, we know that the longer-term prognosis, going out 10 years and beyond specifically, is worse for our patients with ILC compared to their stage-matched comparisons with IDC. And so I think this is, alarming in many ways. How do we actually impact this survival trend? And how do we catch these recurrences? Because you think about when we're intensely following patients in the first 5 years after diagnosis, for our patients with lobular cancers, that may not be when the problems arise. Not that that time's not important, but we really have to have special considerations later on. So what do we do about this? Now that we have this piece of data, it's good to say that it's out there, but if it only causes fear, that's not so great. So in the adjuvant treatment setting, I think one of the ways that we look to optimize most is appropriately giving our most aggressive therapies to patients who will benefit from it and who truly need it. And that's where we come to the use of gene expression assays and chemotherapy, specifically for patients with lobular cancer. And so if you look at the overall use of gene expression assays for hormone-positive early-stage breast cancer, we have many options. So this is just a screenshot of the NCCN guidelines that summarize this topic. And I would say the two that you see most commonly in clinical practice are the Oncotype DX, or the 21 gene recurrence score, or the Mammaprint, which is the 70 gene recurrence score. And both of these tests are NCCN Category 1 evidence-based recommendations, with the Oncotype having the special distinction of being both really predictive and prognostic. So to set the stage, as this will influence a lot of our discussion in the next 10 minutes or so, thinking about a test as being predictive is really estimating how much benefit it can say that a patient would get from a particular therapy. So this is really predicting the benefit of chemotherapy for a patient. Whereas prognostic is talking about their overall disease-related outcome, right, or survival, essentially, disease recurrence numbers. So Oncotype has that distinction of being predictive and prognostic. And then Mammaprint, in its most, I think, data-driven form, really is a prognostic test, but we use it to make those same decisions about chemotherapy. And so when starting with Oncotype, we are an institution that uses a lot of Oncotype. So I would say that a lot of providers in this room are probably familiar with the test and may or may not have sent it on patients with lobular cancers. This is just a summary of the variety of studies that are out there in published literature about what Oncotype scores look like for patients with ILC. And you can see these start at very small single center studies. The first column here, the 2022 Osterreich study, was a combination effort for Cleveland Clinic, Ohio State, and the University of Pittsburgh Medical Center, so our patients are represented there. And then you get out to more national database type studies that obviously represent many more patients. And what I wanted to show as a trend here is that there are patients with lobular cancer who will fall into the high-risk category, although the numbers are very small. So estimated anywhere between about 2 and 8% as patients being identified as genomically high risk and thus being candidates for adjuvant chemotherapy. So I think this probably goes along with what we would intuitively think about with lobular cancer, that these are lower proliferative index tumors, that they tend to be much more hormonally sensitive than chemotherapy sensitive. But I think getting at this is important because there's this large trend in the lobular world that chemotherapy is not effective for patients with lobular cancer. And while it might not be effective for all, it's definitely effective for some. And so finding these patients is really important. When you look at how much impact chemotherapy has for the patients that have either intermediate or high-risk oncotype scores, and I tried to put the ranges of what intermediate and high risk mean for each of these studies because we know that those definitions have changed over time. We generally find that in the earlier retrospective looks at lobular cancer, that there wasn't much chemotherapy benefit seen for those patients with intermediate risk scores, which has been supported for the breast cancer data in general, but interestingly enough, also at high risk scores. And so in these two studies, you see that the curves for patients with intermediate risk, so on the left-hand side of your slide, there's two lines there. In the top part, you can't really see both because they can completely overlap. But the patients with intermediate risk scores who received chemotherapy are in blue, and those who did not receive chemotherapy are in yellow. And you see that the outcomes or survival probability are the same for both groups. And that trend is pretty much the same for the patients with high-risk scores. And it's that high-risk group that you really would expect to see the curve separating more when you think about hormone-positive breast cancer in general. So, this is the first, I think, warning. Maybe chemotherapy is not benefiting our patients as much with higher oncotype scores. But retrospective study, selection bias, a lot of things to think about. And then the study on the right, also from the SEER database, a very similar time point. The patients in this study were a little bit better defined, so we know their T and N stages, whereas the first study I just mentioned was just general stage 1 through 3. So you just wonder what the breakdown of patients in the study was. And then in the second analysis that I'm talking about here on the right-hand side of the slide, we're actually using older recurrence risk ranges. So the intermediate range going from recurrence scores of 18 to 30, and high risk of 30 and above. So I would say those are not our modern numbers. But even when you use those older numbers, there's really no difference in overall survival, or breast cancer specific survival actually, for patients who are in an intermediate or high risk group if they receive chemotherapy or do not. And so up until recently, this is pretty much what we had. And then there was a third analysis that was from the NCDB, so another large national database of patients with breast cancer. And this just showed that overall, when you look at ILC, there's no benefit for chemotherapy in general. Now, this one is not broken down by stage, it's not broken down by recurrence score, so I would take that with a grain of salt, but it is out there, and it's one of the larger analyses that sort of drives this theme about chemotherapy for early stage ILC. Now, what changed things, and I think what we really have to consider is a more modern and very well done analysis that is on the right-hand side of your slide here. And this is looking at oncotype-defined risk for patients with ILC who received chemotherapy. And so the patients with the lowest risk scores in the purple line, the patients in the intermediate risk in the red line, and the patients with the high risk in sort of that green-blue line. And you're looking at survival percentages here, so what we can see is that Oncotype actually did well define different groups, and those patients that were in the highest risk group actually did have worse survival, and in other analyses they show that these patients do benefit from chemotherapy. And so I think that this is our most significant group of patients with ILC that is shown for Oncotype literature. This was over 15,000 patients. And it makes me think a little bit more about that high-risk group and how important it is to find them, even if the odds of finding a high-risk patient are low. And then what about Mammaprint, our other sort of data-driven test in breast cancer for making chemotherapy decisions? So these studies are much smaller, and there's only 2 of them, representing only about 700 patients total. But what you can see in these studies, and Mammaprint is actually it has either a high risk or a low risk. So you take out that intermediate risk that you find with Oncotype. And it really does well differentiate outcomes for patients with lobular cancer. So we see here on the left-hand side of the slide that for those patients that are Mammaprint low risk, they actually have much better overall survival. The second panel is distant metastasis-free interval, and then the third panel is distant metastasis-free survival. And those numbers are distinctly different from their counterparts that are determined to be genomically high risk in the red lines. What we don't entirely know about these groups is how much does chemotherapy impact this. So I think we can say that Mammaprint well differentiates two different risk groups, but how much does chemotherapy impact is really what is left to be decided. In overall clinical practice, if a patient is Mammaprint high risk, we do recommend chemotherapy. So I think it's reasonable to still use that for our patients with lobular cancer. And one of the things that intrigues me about Mammaprint in lobular cancer is that we define a lot more patients as high risk. And so we know that this test includes 70 genes compared to the 21 genes. Are those genes better capturing risk? This is all kind of hypothesis generating. But in these two studies I'm showing you here, between 16 and 24% of the patients were actually classified as high risk. And this is just genomically, right? Their clinical features are going to be in the low to high risk category. And so I think that's important because if we're talking about being better to identify a higher risk population and moving the marker from around 5% of patients up to 8% of patients with Oncotype to potentially the mid-teens to over 20% with Mammaprint, we may be better to able to identify the patients who ultimately are going to have more aggressive disease biology and give them better upfront therapy. But again, small studies, hard to know what to do. I think my takeaway from all of this, though, is that these genomic assays do have a place for patients with lobular cancer. The other thing we see across all of this literature is for eligible patients who could get a gene expression assay if you didn't know their histology. Only about 30% of eligible patients with lobular cancer receive a gene expression assay. So there's clearly some bias here of who we send the test on, who we don't think about the test for, and there's going to be a lot more to the clinical decision making, as we all know. But I think that we should challenge our assumptions that these cancers are not going to be chemosensitive and find the right patients who may actually benefit from that therapy. This is another analysis just of Mammaprint and ILC, and again, what we're seeing here is that the curves are separating. The low-risk group and the high-risk group have different survival outcomes. And this is kind of our closest look at how much chemo impacts that outcome. So in the lower right-hand side of the slide, there's the curves that show the higher-risk patients who received chemotherapy and did not receive chemotherapy. So the red line is the high-risk patients who did receive chemotherapy, and the blue line is the patients who did not. And those curves separate. So if you looked at that without the statistics, I think we would all say chemo probably is making a difference for those patients that are high risk. And there's an 11% absolute difference. But because it's a small group, this was not statistically significant. So I think it's interesting, and I'd love to see it in bigger data sets. And it certainly makes me think that what we use to support decision-making in breast cancer overall should apply to these patients. But I don't have the statistics yet to prove it to you, and I hope that that will come. So what could be next on the horizon? This is a test that I wanted to highlight that we started talking about 5 years ago called LobSig. And this is a gene expression panel that is being developed or has been developed in Australia. And the goal here is to better, again, identify risk groups within lobular cancers and see if we can better predict responses to therapy. And this has been studied in some validated data sets, the Metabrick and the TCGA. There's small results, but it really does seem like we get good discrimination of groups into low, intermediate, and high. And actually, when they compared the risk stratification against our currently available tests, the stratification was better. And so there hasn't been a lot of update about this test since this initial publication came out in 2019, but I think there's a lot of clinical interest, and we hope that it will start being used potentially alongside some of our currently available tests so we can compare how well the tests perform and then follow those patients to see what their ultimate clinical outcomes are. I think the other thing that's really interesting about this data set is that for the patients with lobular cancers who had poor prognosis, we see the same genes coming up. And these are genes that you saw early on in our talks this morning from Dr. Pareja. And then if you look, I think you'll hear more about them in Dr. Ali's talk that follows mine, that these lobular cancers that have poor prognosis tend to be those that have more mutation or expressions in ERBB2, so the HER2 family. TP53, not a surprise, it's just a bad gene to have mutations in. But also two that we might be able to do something about. So AKT and ROS1, which currently have inhibitors that are in development or drugs in development that could target those cancer-inciting mutations that are problematic and result in worse prognosis. So I would keep your eyes on that. Right now I think LobSig is just in development for prognosis, but we really could use it for prediction, hopefully for chemotherapy, and maybe even for other targeted therapy down the line. So what about endocrine therapy for lobular cancer? I mean, these tumors, we know they're very strongly ER/PR positive, over 90% for both ER and PR. And so we know that regardless of what decision you make about chemotherapy, the endocrine therapy is going to be very, very important. And then deciding which endocrine therapy you select or you talk to your patients about is an open area of investigation. This is the best data that we have that looks at a lobular subset for the question of adjuvant endocrine therapy. So this data comes from the big 198 trial, and just to bring us all back to what that trial was, it was an adjuvant treatment trial for postmenopausal women who received one of the following treatment options. So it could be tamoxifen for 5 years, letrozole for 5 years, or sequential therapy. So whether that was 2 years of TAM followed by 3 years of letrozole or vice versa. And the analysis that we're looking at here today is actually a comparison of just the pure 5 years of TAM and 5 years of letrozole, but it's broken down by histology. So out of this big, I think it was 8,000 or 9,000 patients total that participated in the study, only 2,900 of them had known histology, which is kind of sobering actually, and why it makes these trials really hard to do. And out of that 2,900, 324 of them had lobular cancer. And so when you look at the results in terms of disease-free survival and overall survival broken down by which endocrine therapy the patients received, you will actually see that both the IDC and ILC groups benefit more from AI, letrozole compared to tamoxifen, but that the magnitude of benefit is bigger for the patients with lobular cancer. So how that actually looks on these survival curves are that the patients with ductal cancer are represented in the solid lines, and those who receive letrozole are in the blue solid line, and those who receive tamoxifen are in the yellow solid line. So let's see if I can get the pointer going here. There we go. So that you're looking really between the difference of these two solid lines in the middle here. So they're pretty close, but it's clear that the blue solid line is higher up on the curve, meaning better survival, than the yellow. So this is kind of our general impression that AIs do better than tamoxifen for postmenopausal women with hormone-sensitive breast cancer. Now the dotted lines here are actually those patients with lobular cancer. And so you can see that the dotted line in yellow are the lobular cancer patients who receive tamoxifen. And they actually have the worst disease-free survival over all the patients that are seen in this analysis, compared to those patients who are lobular cancer that received AI that actually have the best line up there, pretty similar to the ductal patients who received AI. So the difference here in 8-year disease-free survival, so it's capturing a longer endpoint at that time where we're seeing lobular patients having recurrences, the magnitude of benefit is larger here for those patients with ILC. So going from a disease-free survival of 66% up to 82%, compared to the ductal patients who were 75% with tamoxifen going up to 82% with letrozole. And that same trend bore out in overall survival. So when I'm talking to patients about endocrine therapy, I'm trying to favor AIs for those who are candidates for it. Now, that can be hard in a lot of ways. Patients may have comorbidities that make it challenging to give an AI, and bone health being a big one there. Tolerability profile is different between tamoxifen and AIs. So we work through that, but I think if you're going strictly from a data perspective, even though it's a really, really small analysis, it's one of these themes that we see in ILC that aromatase inhibitors are probably the preferred endocrine therapy. There's a lot of work going on about tamoxifen resistance in lobular cancers, which I don't have the knowledge or time to get into with you today, but I think that that is one of the main areas of concern. So what about if a patient doesn't get that pure 5 years of AI? What if they start with tamoxifen and then switch over to an AI? Is that still okay? Do they still get the same benefit? And the short answer is yes. So this is a subset analysis from the TEAM trial. And in this study, patients were randomized, when study was first conceived, to tamoxifen or exemestane, our steroidal aromatase inhibitor. And then once we started to have the data about aromatase inhibitors being superior to tamoxifen in general, the study was changed so that both arms were getting the exemestane, which resulted in a sequential treatment arm for those who had gotten initial tamoxifen and then went on to exemestane. And the primary endpoints of the study were looking at disease-free survival at 2.75 years, or about halfway through, and then 5 years. And what we actually see here is the survival for both IDC and ILC, regardless of if the patient started with tamoxifen and then went to exemestane, or started with exemestane period, that there's a non-statistically significant difference in 5-year survival with either approach. So you see again in this ILC group a little numerical difference here, but doesn't bore out statistically. So at least the way that I'm looking at this is if a patient starts with tamoxifen and is willing to switch to an AI over time or becomes eligible to switch to an AI over time, that I will use that data to give them some time on an aromatase inhibitor. So now what about breast cancer index? So a lot of what I just talked to you about is about decision making in the first 5 years of endocrine therapy. So what about going on to extended endocrine therapy? And I think this is a gut reaction for a lot of us who treat lobular cancers that can have these late recurrences. Well, what if you just keep their endocrine therapy going longer? Is that going to fix the problem? And you would hope that the answer is yes, but the answer is probably no, not for most patients. So breast cancer index is a gene expression test that really gets at that question. So it's giving you 2 pieces of information. The first is a predictive result to say, will this individual patient of mine benefit from endocrine therapy in the period of year 5 to 10, so going beyond 5 years. And then there's a prognostic result that's really looking at the risk of late recurrences. So you would think, hey, this might be beneficial for my patients with lobular cancer, where we talk so much about the late recurrence risk. And so this test is run off of the original breast cancer tissue, so it's usually something that we have in the freezer and we take back out for patients and send it. And what you can see when it's been looked at, it's very, very well validated in breast cancer overall, but it has been looked at specifically in ILC, which is what I am showing you here on this slide. And we know that it is still a predictive test for those patients with ILC, and it actually is most predictive for those late distant recurrences. And let me go back. So that information is here to the far right-hand side of the slide, that for those patients who fall into the high-risk group on breast cancer index compared to the low-risk group, that they actually do have benefit and less risk of recurrence when they receive extended adjuvant endocrine therapy. And then the prognostic piece holds true as well, and you see, again, more of the prognostic pieces impacting that late recurrence risk. And so I think this is helpful information because usually at the 5-year mark, patients are, they may be feeling like, should I continue on? For some patients, the treatment is a security blanket. For others, they say, I'm tired of these toxicities. Should I stop or am I doing myself a disservice? And this test really helps us get at, the most individualized risk that we can find and really predicting, even if your risk is high, is anti-estrogen therapy for a longer period of time going to change that? Thankfully, most of the patients who have this test run, their results are concordant, meaning if the risk is high, then extending the endocrine therapy benefits them. Where it's really tough is when the risk is discordant and you have somebody with a high risk of late recurrence, but the top result is a no, meaning extending the endocrine therapy is not going to help them. So again, thankfully those results are pretty rare, but when you do find them, it makes us wonder, is this a group of patients that we could expose to other newer novel therapies, targeted therapies at our disposal to help mitigate that risk? But there's really no evidence that helps us right now. And this is another look at breast cancer index in IDC versus ILC. This is newer data that was presented at the San Antonio Breast Cancer Symposium in 2022 by Otto Metzger's group. And again, what you find here is that the BCI results are valid for our patients with ILC. When you compare IDC and ILC, you actually find, and this was surprising to me, a higher risk for late recurrence more commonly in the IDC group compared to the ILC group, which I think is not what any of us would have expected, and that was statistically significant. And the higher likelihood of benefit from extended adjuvant endocrine therapy was pretty much the same between IDC and ILC. So again, it's sort of saying this biology is really important, but then challenging some of the assumptions about what we do. Are all of our treatment decisions going to be different for IDC and ILC? Well, clearly not. And I think this is why having the data is so important, because I would have assumed that the risk of late recurrence would have been much higher for ILC than IDC. And then the last line here in this little table that I created is those patients with a high benefit of endocrine therapy and high risk of recurrence, that combination, again, was also higher in the IDC compared to the ILC population. And then when you look at this, on the right-hand side of the slide, there's just some data that was in the same abstract from the ideal translational cohort. And this is another one of those longer-term endocrine sequencing studies. So patients here received essentially either 7.5 total years of endocrine therapy versus 10 total years of endocrine therapy. After their initial 5 years could have represented any of our options, tamoxifen alone, aromatase inhibitor alone, or a sequence of the two. And when you look at this, the numbers are pretty much the same. For those patients with ILC, consistently you're going to find about a third, a little more, that have a high risk of late recurrence. And then for those patients, there is benefit of extending the adjuvant endocrine therapy beyond 5 years. And for those patients with a low predictive result that would not benefit from it, they really, truly do not benefit. So what open questions do we have? There are many. And in the interest of time, I will save a lot of these for you. But optimal duration of therapy is a challenge. The role of adjuvant CDK4/6 inhibitors is a challenge. And the role of ovarian function suppression for women who are very young with ILC is also a significant challenge. I have a whole nother section of neoadjuvant considerations, but I think we're at time. So I'm going to stop there and maybe come back around to this when we're in the question and answer period. And this is more future-looking ideas for clinical trials and such. So we'll move to the metastatic ILC section now, and then we can come back around and all the slides will be available for your review. So we can, if we want to pop up the slides for our next presenter, Dr. Ali.